Hello, dear students. The topic today is meningococcal diseases in children. And second topic today is scarlet fever in children. The first part, we will start. Etiology. Neisseria meningitidis is an encapsulated gram-negative diplococcus. There are at least 12 serogroups of the bacterium based on capsular polysaccharide antigenic differences. Serogroups A, B, C, Y, and W, 135 cause 90% of human disease. It is gram-negative intracellular diplococci, as present in picture below. Meningococci have three important virulence factors as follows. Polysaccharide capsule. Individuals with immunity against meningococcal infections have bactericidal antibodies against cell wall antigens and capsular polysaccharide. A difference of circulating anti-meningococcal antibodies is associated with disease. And the next, lipo-oligosaccharide endotoxin and immunoglobulin A1. A polysaccharide capsule, which also determines the serogroup, enables the organism to resist phagocytosis, such as anti-immunity attack. Resist. Lipo-oligosaccharide endotoxin. This is considered the principal factor that produces the high endotoxin levels in meningococcal sepsis. Meningococcal lipo-oligosaccharide interacts with human cells, producing pro-inflammatory cytokines and chemokines, including interleukin-1 and interleukin-6 and a tumor necrosis factor. Lipo-oligosaccharide is one of the important structures that mediate meningococcal attachment to and invasion into epithelial cells. Transmission. The human nasopharynx is the only known reservoir for Neisseria meningitidis. The organism is transmitted via aerosols and nasopharyngeal secretions. Meningococcal infection is presented by nasopharyngeal colonization, as it present in picture below. One of the mildest forms of meningococcal infection is meningococcal nasopharyngitis, which is similar in symptoms to a common cold, no any specific symptoms. The patient is most epidemiologically dangerous to other people. Meningococci then enter the bloodstream and spread to specific sites, such as the meninges or joints, or disseminate throughout the body. 5% of individuals become long-term carriers. Most of them are asymptomatic. In this picture, you can see what strains, what serologic strains in different countries, such as in Russia. More common B, C, W, X, and Y serotypes, and in China A, C, B, and W 135 and Y and X, and in India A, C, Y. It is important for change any vaccine, any contain of vaccine for protection meningococcal infection. Neisseria meningitidis remains a major infectious cause of childhood death in developed countries. In this infographic, you can see that 1 out of every 10 people with meningococcal disease will die or suffer lifelong disabilities. And learn more about the disease that can be prevented by vaccines. The mortality rate remains around 10%, although in some specialist centers it has decreased to less than 5% overall. There are any risk factors. Most patients with meningococcal disease were previously healthy. However, patients with certain medical conditions are at increased risk of developing meningococcal infection. Risk factors include the following: close contact with a patient with primary invasive disease and recent viral respiratory illness such as influenza. Then smoking or exposure to secondary smoke, socio-economic deprivation, host susceptibility, individuals with deficiency of complement components 5 and 9, and abnormal complement factor AH. Individuals with human immunodeficiency virus infection and patients with anatomic or functional asplenia are also at increased risk of invasive meningococcal disease. There are different clinical forms, and we watch on clinical classification. Pay attention, please. There is localized forms, there is generalized form, and rare forms. Localized forms, this is carriage and nasopharyngitis. It is light form of this disease, and there are different generalized form. It is meningococcemia, purulent meningitis, and mixed forms, such as meningococcemia and purulent meningitis in one patient. And rare forms, this is endocarditis, arthritis, iridocyclitis, and others. Patients with acute meningococcemia. Meningococcemia is defined as dissemination of meningococci, Neisseria meningitidis, into the bloodstream. It is sepsis. May present with one of three syndromes: meningitis, meningitis with meningococcemia, or meningococcemia without obvious meningitis. Of cases of invasive meningococcal disease, 30 to 50% with meningitis alone, 40% have meningitis with bacteremia, and 7 to 10% have invasion of the bloodstream alone. Pathophysiology. The fundamental pathologic change in meningococcemia is widespread vascular injury characterized by endothelial necrosis, intraluminal thrombosis, and perivascular hemorrhage. The deleterious effects of cytokines play a major role in the pathogenesis of meningococcemia by causing severe hypertension, reduced cardiac output, and increased endothelial permeability. In this picture, you can just see pathogenesis of this disease. On the first stages, passage through the mucus of meningococci, and the next stage in blood, survival in the bloodstream, and the third stage, crossing of the blood-brain barrier, and Neisseria meningitidis may multiplication in subarachnoid space. In this picture, you can see the stages of process. Patients with fulminant meningococcemia develop thrombosis and hemorrhage in the skin, the mucous membranes, the serosal surfaces, and adrenal sinusoids, and the renal glomeruli. Adrenal hemorrhage is rarely extensive. Thrombosis of the glomerular capsules may cause renal cortical necrosis. The chief characteristic of dissemination intracirculation coagulation: thrombi containing numerous leukocytes, are occasionally found in the lungs, and extensive intra-alveolar hemorrhage can occur. Myocarditis, when it occurs, carries a poor prognosis with a high mortality risk. In this picture, you can see children with meningococcemia, and on the skin you can see massive hemorrhagic necrosis, hemorrhagic rash. It is very important symptom for this disease, and all these patients receive treatment in intensive care unit or resuscitation unit, and their condition is severe. Characteristic hemorrhagic rash. You should remain this rash for diagnosis severe forms. Septicemia. The clinical spectrum of meningococcal septicemia is produced by 4 basic processes: capillary leak, coagulopathy, metabolic derangement, myocardial failure. Combined, the process produce multi-organ failure that usually causes cardiorespiratory depression and possibility renal, neurologic, and gastrointestinal failure. Hypovolemia that is resistant to volume replacement is associated with increased mortality due to meningococcal sepsis. Children with severe disease often require fluid resuscitation involving volume several times their blood volume in the first 24 hours of the illness, mostly in the first few hours. Pulmonary edema is common and occurs after 40 to 60 milliliter per kilogram of fluid has been given. It is treated with artificial ventilation. In meningococcemia, severe bleeding tendency is often simultaneously present with severe thrombosis in the microvasculature of the skin, often in the glove and stocking distribution that can necessitate amputation of digits or limbs. Clinicals face a dilemma because supplying platelets, coagulation factors, and fibrinogen may worsen the process. Hypokalemia, hypocalcemia, hypomagnemia, and hypophosphatemia may occur in the setting of severe acidosis. Myocardial failure may be during course of this disease. Myocardial function remains impaired even after circulating blood volume is restored, and metabolic abnormalities are corrected. Severity of disease is related to the degree of myocardial dysfunction. Meningococcal infection leads to human coronary microvascular thrombosis, vasculitis, and vascular leakage. Other factors that reduce myocardial function, such as acidosis, hypoxia, hypoglycemia, and electrolyte disturbances, are all common in severe meningococcal disease. Meningitis. It is one of all forms, and meningococcal meningitis generally has a better prognosis than septicemia, than meningococcemia. After bacteria enter the meninges, they multiply in the cerebrospinal fluid and appear arachnoid. In the early stages of infection, the tight junctions between the endothelial cells that form the blood-brain barrier isolate the cerebrospinal fluid from the immune system. This isolation allows bacterial multiplication. Eventually, inflammatory cells enter the cerebrospinal fluid and release cytokines that play a central role in the pathophysiology of meningeal inflammation. In this infographic, you can see main symptoms of meningitis in infants. You should remember these symptoms. It is fever, high fever, 38, 39 degrees of Celsius, turning away from lights, stiff neck, aching of the back, um, being pre-crash, very important symptoms, cold hands and feet, refusing to feed, vomiting, shivering and extreme sleepiness, bulging fontanel, irritability, crying, seizures, different symptoms uh, which central nervous system. Neurologic damages is a consequence of the following three main processes: direct bacterial toxicity, indirect inflammatory process such as cytokine release, ischemia, vasculitis, and edema, and systemic effects including shock, seizures, and cerebral hyperperfusions. Cerebral edema may be caused by increased secretion of cerebrospinal fluid, diminished reabsorption of cerebrospinal fluid, and/or breakdown of the blood-brain barrier. Reduced cerebral blood flow with vasculitis and thrombosis of cerebral vessels may cause ischemia and neuronal injury. Signs and symptoms. Remember and repeat. Patients with acute meningococcal may present with meningitis alone, only meningitis, meningitis and meningococcal without clinically apparent meningitis. And in this picture, you can repeat all symptoms. In this picture too, can repeat symptoms of meningitis: fever, vomiting, severe headache, stiff neck, dislike of bright lights, seizures, rash, hemorrhagic rash, very sleepy, confused, delirious maybe. Meningococcal is characterized by the following. It is fever, initial rash that may be erythematous or maculopapular, short-lived, followed by petechia and purpura. Vomiting, headache, myalgias that may be quite severe. What else symptoms? Sore throat, abdominal pain, tachycardia, tachypnea, hypertension, cool extremities, initially normal level of consequences. Early symptoms are similar to those of viral illnesses, such as influenza or streptococcus pharyngitis maybe. However, this infection accelerates at a rate matched by few other infections. In this picture, you can see a 9-month-old baby in septic shock with peperic Neisseria meningitis, skin lesions. Physical examination. Patients with meningococcal disease appear severely ill. Tachycardia and mild hypertension are present. Patients with acute meningococcal usually present with moderate fever, average 39.5 degrees Celsius, and no signs of shock. High fever is present in fulminant meningococcal, very severe forms. Patients with fulminant meningococcal rapidly deteriorate clinically with hypertension and respiratory failure. Pericarditis can occur during the acute disease or in the recovery period and is associated with serogroup C disease. Clinical presentation. Symptoms of meningococcemia may include any of the following: a non-specific prodrome of cough, headache, and sore throat. The above followed by a few days of upper respiratory symptoms, increasing temperature and chills. Subsequent malaise, weakness, myalgias, headache, nausea, vomiting, and arthralgias. The characteristic petechial skin rash is usually located on the trunk and legs and may rapidly evolve into purpura. Repeat symptoms. So the meningitis of meningococcemia is associated with the following: headache, fever, vomiting, photophobia, lethargy, neck stiffness, rash, seizures. And the next. Dermatologic manifestation. Petechia develop in 50% to 80% of patients with meningococcal disease and commonly begin on the trunk and legs in areas where pressure is applied. Petechia are discrete lesions 1 to 2 mm in diameter. Concerns of lesions results in hemorrhagic patches, often with central necrosis. In some cases, a transient maculopapular rash develops, usually lasting for less than 48 hours. Rash may be missed early in an individual with dark skin. Dermatologic. What else? Skin lesions tend to occur in cross on any part of the body, occasionally presenting on the conjunctive and mucous membrane. The face is usually spot, and the involvement of the palms and the soles in is less common. In this picture, you can see glass test when we pressure on rash, and this rash disappeared. Hemorrhagic rash not disappeared. If we have inflammatory rash, his disappeared. But on the first picture, we have hemorrhagic rash, which not disappeared on pressure. Bacterial meningitis is a febrile illness of short duration. The main symptoms include headache and a stiff neck. Lethargy or drowsiness is common. Confusion, agitated delirium, and stupor are rare. However, coma is and ominous prognostic signs. The clinical patterns of bacterial meningitis is often atypical in young children because headache and stiff neck are frequently absent. Irritability, especially upon movements, is a common presenting manifestation of meningitis in a young child. Convulsions may signal on the onset of meningitis at this age. Only one symptom. The characteristic physical examination findings on meningitis include pain and resistance to neck flexion. Other signs of meningeal irritation can also be elected. Children with meningitis may have none of these findings. Focal neurologic signs are uncommon, presenting finding of bacterial meningitis. However, resistance of neck flexion may not be elected in patients who are comatose and who may have signs of focal or diffuse neurologic deficiency. In this picture, you can see position of children with meningitis. It is specific position for on this disease. And in this picture, the Brudzinski sign is positive when neck flexion causes involuntary flexion of the thighs and the legs. And the next picture, the Koenig sign is positive when the leg cannot be extended more than 135 on the thigh when flexed 90 at the hip. And conclusion about it, dermatologic manifestation, petechia, rash, ecchymosis, purpura, meningococcal meningitis, pain and resistance to neck flexion. Other signs of meningeal irritation, petechia, fever. Fulminant meningococemia, purpuric eruption, hemorrhages on buccal mucus and conjunctive. No signs of meningitis, cyanosis, hypertension, profound shock, high fever, pulmonary insufficiency, and meningococcal septicemia. Fever, rash, tachycardia, hypertension, cool extremities, initially normal level of consequences. Differential diagnosis. The Kujanow's differential diagnosis of acute meningococemia encompasses multiple entitles, including other infectious processes such as leptospirosis, Rocky Mountain spotted fever, and different acute viral syndrome. Other differential diagnoses for acute meningococemia include acute hypersensitivity vasculitis, septic vasculitis due to acute bacteremia or endocarditis, toxic shock syndrome, and purpura fulminans. All the causes of purpura or petechia, only 2 to 11% of children with petechia and fever have invasive meningococcal disease. Also, most other children probably have viral infections. Antibiotic therapy should be commenced without awaiting additional information. Distinguishing meningococcal disease from other causes in these cases is difficult, and their fatality rate is high. Other causes may include the following: different bacterial infections, pneumococcal septicemia, group A streptococcal septicemia, and viral infections. There are Epstein-Barr virus infection, enterovirus infection, measles, rubella, herpes-simplex virus infection, cytomegalovirus infection, hemorrhagic viral fevers, different, and other infections, mycoplasma infections, Rocky Mountain spotted fever, epidemic typhus, ehrlichiosis, leptospirosis, and big part of platelet disorders. It is immune thrombocytopenia, leukemia, Bernard Shaw disease, and Glanzmann disease. Laboratory findings is the earliest stage of meningococcal disease are often non-specific. Definitive diagnosis requires retrieval of meningococcal blood from blood, cerebrospinal fluid, or skin lesions. Laboratory diagnosis. What tests require complete blood count with white blood cell count, blood urea nitrogen and creatinine, fibrinogen and C-reactive protein, coagulation studies, electrolytes, blood and throat cultures, and imaging studies such as chest radiography, echocardiography, magnetic resonance imaging, and very important to perform lumbar puncture and cerebrospinal fluid analysis, and serogrouping, serotyping, and very quick and very sensitive, now very sensitive and very Good analysis on this time. It is real-time PCR, very quick result. Blood culture is meningococcal. In meningococcal infection, produce transparent, non-pigmented colonies that are oxidase positive and non-hemolytic. Overall, the sensitivity of blood culture is 50 to 60%. In untreated patient, not antibiotic-treated patient, before antibiotic, perform the blood culture before the administration of antibiotics. Rapid latex antigen tests may assist with diagnosis. The latex agglutination tests have 50 to 100 sensitivity and high specificity, but it has a high rate of false negative result. Throat culture should be obtained. However, the diagnosis of meningococcemia cannot be made solely from a positive result from throat culture because asymptomatic colonization is not uncommon. In patients with meningococcal infection, the white blood cells count and C-reactive protein level may be elevated at presentation or may increase during their subsequent 24 hours. However, their values are not reliable markers of infections. A low white blood cells count is a poor prognosis finding and should raise concerns about disease rapid progression. Dissemination intravascular coagulation is a laboratory diagnosis because very important coagulation tests, but no single laboratory test is diagnostic. Instead, dissemination intravascular coagulation is recognized clinically by a patient of changes in numerous coagulation tests. Typically, these changes include lowered platelet count, prolonged prothrombin time, prolonged partial thromboplastin time, lowered fibrinogen levels, and the presence of fibrin split products in the circulation. Not all of these changes are found in all patients. Fibrinogen, an acute phase reactant, may be elevated in patients with dissemination intravascular circulation. Imaging stages. Chest radiography is useful to evaluate for pneumonia and acute respiratory distress syndrome. Echocardiography can be used to evaluate for myocardial dysfunction and pericarditis. Meningococcal polymerase chain reaction is a rapid method of diagnostic cerebrospinal fluid infection. PCR of spinal fluid yields sensitivity and specificity of more than 90% in the diagnosis of meningococcal meningitis. It is useful when antibiotics have been administered and can be used to rapidly type strains in developing epidemics. Lumbar puncture. Bacterial meningitis produce various inflammatory changes in the cerebrospinal fluid. The cerebrospinal fluid becomes turbid with more than 1,000 white blood cells per milliliter, and the cells are predominantly polymorphonuclear. The total protein content is increased, and the glucose level, which is normally 60% of the simultaneous blood glucose level, becomes lowered, hypoglycemia. Care, medical care, inpatient care. Hospitalization is required for severely ill patients with fever, headache, and petechia. Promptly begin antibiotic treatment. Respiratory precautions generally include placement of the patient in a private room with proper air handling, and the use of a respiratory mask by any person entering the patient's room. Monitor blood pressure, urine output, and cardiac function, as well as platelets, fibrin, and fibrin degradation products. Supportive care may be needed, includes maintenance of fluid and electrolyte balance, and vasoactive drugs in shock, such as dopamine, or adrenaline. Suspect fulminant meningococcemia in a patient with hypertension and severe coagulation abnormalities. In such cases, monitoring in an intensive care setting is required. Meningococcemia treatment and management. Because mortality may be reduced with early antibiotic therapy, patients with a meningococcal rash should receive parenteral antibiotics by means of an intravenous or intramuscular route as soon as the diagnosis is suspected. Intramuscular antibiotic injections may be less effective in patients with shock and poor tissue perfusion. Other than antimicrobial treatments, supportive measures in meningococcal disease may be needed to correct circulatory collapse. Any adrenal insufficiency requires corticosteroid replacement, corticosteroid therapy. Medical care of meningococcal infections should also address community management and the emergency management of meningococcal septicemia and meningitis. This may include treating shock and increased ICP, as well as the use of new and experimental therapies. Penicillin G has been the antibiotic of choice of susceptible isolates. A third-generation cephalosporin, such as cefotaxime, ceftriaxone, can be used initially in septic patients while their diagnosis is being confirmed. Because their easy administration schedule, the third-generation cephalosporins have become their preferred class of antibiotics. These cephalosporins penetrate sufficiently into cerebrospinal fluid from blood and are useful in the treatment of bacterial meningitis. They are known to have a potent action against meningococci. Empiric antibiotic therapy for meningitis based on age is as follows. Neonates, it is ampicillin and cefotaxime. Infants aged 1 to 3 months, ampicillin and cefotaxime. Older infants, children, and adults, cefotaxime or ceftriaxone. Management shock. After basic life support and antibiotics are administered, the next priority is treating shock. Basic life support should include the administration of oxygen by means of a facial mask. The initial therapy for shock is volume replacement at a rate of 20 milliliter per kilogram with used normal saline solution. A satisfactory response to volume replacement is a reduction in head rate and improved peripheral perfusion. The first bolus of fluid may be replaced to achieve this response. The patient's condition may stabilize with only volume replacement, but the patient requires close monitoring and reassessment to detect further signs of shock or pulmonary edema. The goal of circulatory support is to maintain tissue perfusion and oxygenation. Patients who don't respond to initial volume replacement require further volume replacement and may need inotropic support such as use of dopamine or dobutamine, which may be administered via a peripheral vein until central venous access is established. Patients with persistent hypertension may need an infusion of adrenaline, which must be administered via central venous access. Corticosteroid therapy. Corticosteroids are the drugs of choice for relief of edema and swelling of the brain with severe forms of meningitis and meningoencephalitis. Corticosteroids are used to relieve shock. The dose depends on the degree of shock, and the first degree prednisolone, such as 5 to 10 milligram per kilogram, and second degree of shock 20 milligram per kilogram, and third degree of shock they are big doses of corticosteroid, prednisolone, hydrocortisone, and dexamethasone. Suspect increased ICP, intracranial pressure, if the patient has a decreased level of consequences, focal neurologic signs, inequal, dilated or pool reactions, pupils abnormal, post-raising of or seizures, or relative hypertension or bradycardia, or if the patient is agitated or combative. After correcting shock with volume replacement and inotropic support as necessary, cautiously manage their fluid balance to avoid further increasing the intracranial pressure. Consider the use of mannitol followed by furosemide when increased intracranial pressure is suspected. In addition, find and correct biochemical abnormalities and treat seizures if present. Complications. Complications of meningococcal may occur at the time of acute disease or during the recovery phase. Patients with fulminant meningococcal may develop respiratory insufficiency and require mechanical ventilation. Those with severe dissemination intravascular coagulation may bleed into their lungs, urinary tract, and gastrointestinal tract. Ischemic complications of dissemination intravascular coagulation have been reported in up to 50% of severe or fulminant meningococcal. Complications of meningococcal infection include immune complex disease leading to arthritis, pericarditis, myocarditis, and pneumonitis 10 to 14 days after the primary infection. Up to 5% of patients with meningococcal develop a non-purulent pericarditis with substernal chest pain and dyspnea approximately 1 week after their onset of illness. Involvement of the pericardium in meningococcal disease is a well-recognized but rare complication. In different cases, require surgical treatment of ischemic complications. Patients who survive the initial acute phase of fulminant meningococcal are at increased risk for serious complication as a result of poor tissue perfusion. Early in the course of tissue injury, conservative therapy is recommended until a distinct line of demarcation is apparent between viable and non-viable tissue. Once the patient is stable, Debridement of all necrotic tissue is essential and may necessitate extensive removal of skin, subcutaneous tissue, and muscles. In this picture, you can see a patient with meningococcal with big part of skin and big rash, big massive rash, hemorrhagic rash with damage of perfusion. And on the next picture, you can see a result of surgical therapy because there are most part of ischemic tissue. Monitoring and follow-up. Pericarditis can occur while patients are recuperating from meningococcal. Later skeletal deformities are rare, but epiphyseal vascular necrosis and epiphyseal metaphyseal defects have been described. Observe patients for any late neurologic sequelae, abnormal findings on electroencephalography or cerebral computed tomography scanning, as well as epileptogenic activity, sensorineural hearing loss, impaired vestibular function, and neuropsychological impairment have been found in up to 30% of civils 1 year after an episode of meningococcal disease. The frequency of serious neurologic sequelae in individuals who survive an episode in 3%. Follow-up care at least 6 weeks after meningococcal infection should include the following: ongoing management of specific complications such as amputation, skin grafting, or renal failure, or full physical examination, serologic confirmation of the diagnosis if no diagnosis was made at the time of presentation, audiologic function testing, basic assessment of physiological status after intensive care, if relevant, possible vaccination of contacts if an outbreak of group A, C, Y, or W135 disease occurs. Prognosis. Cases of meningococcal meningitis without coma or focal neurological defects have markedly better outcomes. Most of these patients recover completely when appropriate antimicrobial therapy is administered promptly upon presentation. Isolated meningococcal meningitis, 5% mortality rate, has a better prognosis than meningococcal septicemia, 10 to 40% mortality rate. Patients with higher bacterial loads on polymerase chain reaction testing are more likely to die or have permanent disease sequelae and experience longer hospital stays. Prevention. Antimicrobial hemoprophylaxis of close contacts is the primary means of preventing secondary cases of sporadic meningococcal disease. Person-to-person transmission can be interrupted by administration of an antimicrobial that eradicates the asymptomatic nasopharyngeal carrier state. Sulfonylamides, rifampicin, minocycline, ciprofloxacin, and ceftriaxone are the drugs that have been shown to eradicate meningococci from the nasopharynx, but sulfonylamides, rifampicin, minocycline, and ciprofloxacin only in adults, and in children we used ceftriaxone, cephalosporin antibiotics, and penicillin for therapy carriage. Because the rate of the disease in secondary contacts is highest immediately after the onset of the disease in the patient, hemoprophylaxis should be administered as soon as possible, preferably within 24 hours. If hemoprophylaxis is delayed by more than 14 days, it is probability of limited value. Also, it is still recommended until 4 weeks after the patient's presentation. Vaccination, it is very important for prophylaxis this infection because this infection, as you see in presentation, very dangerous in the different cases. Purified polysaccharide vaccine against encapsulated bacteria are poorly immunogenic in young children because in contrast the conjugate vaccine of group C meningococci, in which the serogroup C meningococcal polysaccharide is conjugated to the protein, appears to prove immunogenic protection to young children. Young children must vaccinated with conjugated to the protein polysaccharide vaccine. But adults can vaccinated with polysaccharide vaccine. There are different type of vaccines such as Menactra. Menactra contains serogroup A, C, Y, and W. 135. Meningococcal A vaccine Russia. There is this vaccine, and Meningo A plus C. Sanofi Pasteur France vaccine there is, and Mencevax, GlaxoSmithKline, one dose 0.5 milliliter from 2 years, and all the children under 6 years of age are vaccinated 14 days before diphtheria. The vaccine is administered strictly subcutaneously. And it is all. The first part is complete. And the second part of our webinar today is scarlet fever in children. Scarlet fever is a syndrome characterized by exudative pharyngitis, fever, and bright red exanthem. It is caused by streptococcal pyrogenic exotoxins types A, B, and C, produced by group A beta-hemolytic streptococci, found in secretions and discharge from the nose, ears, throat, and skin. Scarlet fever may follow streptococcal wound infection or burns, as well as upper respiratory tract infections. Foodborne outbreaks have been reported. Re-emergence of the condition is being recognized, perhaps because of newer virulence of the streptococcal bacteria. Ordinary scarlet fever develops from a tonsillar pharyngeal focus, although the rash develops in less than 10% of cases of strep throat. Exotoxin is of the greatest importance in the pathogenesis of the disease. Exotoxin-mediated streptococcal infections range from localized skin disorders to the widespread eruption of scarlet fever to the uncommon but highly lethal streptococcal toxic shock syndrome. Etiology. Scarlet fever is a streptococcal disease. Streptococci are gram-positive cocci that grow in chains. They are classified by their ability to produce a zone of hemolysis on blood agar and by differences in carbohydrate cell wall components They may be alpha hemolytic, beta hemolytic, or gamma hemolytic types. Group A streptococci are normal inhabitants to the nasopharynx. Group A streptococci can cause pharyngitis, skin infections, pneumonia, bacteremia, and lymphadenitis. Most streptococci excrete hemolyzing enzymes and toxins. The erythrogenic toxins produced by GAPs are the cause of the rash of scarlet fever during scarlet fever. Epidemiology of infections may occur year-round. The incidence of pharyngeal disease is highest in school-age children during winter and spring, and it is setting of crowding and close contact. Person-to-person spread by means of respiratory droplets is the most common mode of transmission. The incubation period of scarlet fever ranges from 12 hours to 7 days. Patients are contagious during the acute illness and during their subclinical phase. Scarlet fever predominantly occurs in children aged 5 to 15 years. Also, it can also occur in older children and adults. By the time children are 10 years old, 90 have developed lifelong protective antibodies against streptococcal pyogenetic exotoxins, which prevent further disease manifestation. Scarlet fever is rare in children younger than 1 year because of the presence of maternal anti-exotoxin antibodies and lack of prior sensitization. Pathophysiology. They are circulating toxin produced by GAPs and often referred to as erythemogenic or erythrogenic toxin cause their pathognomic rash as a consequence of local production of inflammatory mediators and alternation of the cutaneous cytokine milieu. This results in a sparse inflammatory response and dilatation of blood vessels, leading to the characteristic scarlet color of the rash. Usually, the sites of GAPS replication in scarlet fever are the tonsils and pharynx. Clinical manifestation. Main clinical symptoms: incubation period 2 to 3 days about it, or 1 to 7 days. Not very long. And main symptoms: fever 39 degrees Celsius. Fever may be prolonged, such as 1 week during 1 week. Pharyngitis, red exudation, sore. Rash 24 hours after fever. Diffuse erythema 1 millimeter, postauricular, neck, chest, limbs localized. Combined signs: circumaural pallor, pasteous lines, raspberry tongue, and strawberry tongue then. Desquamation and no pigmentation. It is mild symptoms of scarlet fever. The cutaneous eruption of scarlet fever accompanies a streptococcal infection at another anatomic site, usually the tonsillopharynx. The illness generally has a 1 to 4 day incubation period. It is emergence tends to be abrupt and usually heralded by sudden onset of fever associated with sore throat, headache, chills, nausea, myalgias, and malaise. Young children may also present with vomiting, abdominal pain, and seizures. The characteristic rash appears 12 to 48 hours after the one-stop fever, first on the neck and then extending to the trunk, the extremities. In the untreated patient, fever peaks by the second day. Temperature as high as 103 to 104 degrees of Fahrenheit and gradually returns to normal in 5 to 7 days. Fever abates within 12 to 24 hours after initiation of antibiotic therapy. Very rapid effect of antibiotic therapy. And in this picture, you can see infographic with main clinical symptoms of scarlet fever. It is fever, it is strawberry tongue, it is sore throat, and rash and skin pigmentation. And rash on scarlet fever rash, and pustuous lines in this picture on body, on child body. What changes in oral cavity? Exudative pharyngitis and tonsillitis, and an anthem characterized by small red hemorrhagic spots on the hard and soft palate, as you see in this picture. The pharynx is usually bifliate with edema involving the tonsillar area extending anteriorly to the soft palate of uvula. In this picture, you can see pharyngitis. It is pharyngitis causing by group A beta hemolytic streptococcus. A very red mucus, very red throat, and edema tonsillar. The tongue, very interesting changes on tongue during scarlet fever in children. Initially, it is convexed. It is covered with a yellowish white coat, through which may be seen the red papillae. It is the first stage white strawberry tongue, and later the coating disappears and the tongue is beefy red in appearance, red strawberry tongue. The rash usually appears on the second day of clinical illness as a diffuse red blush with many points of deeper red that blanch on pressure. It is often first noted over the upper part of the chest and then spreads to the remainder of the trunk, neck, and extremities. The skin rash fades over the course of 1 week and is followed by extensive desquamation lasting for several weeks during long period desquamation. In this picture, you can see different localized of rash during scarlet fever on palms, on hands, on chest, and on face, particularly on cheeks. The patient usually appears moderately ill. Fever may be present on physical examination. The patient may have tachycardia. Tender anterior cervical lymphadenopathy may be present. The mucous membranes usually a bright red, and scattered petechia and small red papular lesions on the soft plate are often present. On day 1 or 2, The tongue is heavily coated with a white membrane through which edematous red papilla protrude, a classic appearance of white strawberry tongue. By day 4 or 5, the white membrane sloughed off, revealing a shiny red tongue with prominent papillae, red strawberry tongue. Red edematous exudative tonsils are typically observed if the infection originates in this area. Generally, the exanthem develops 12 to 48 hours after the onset of fever, first appearing as erythematous patches below their ears and on the neck, chest, and axilla. Their characteristic exanthem consists of a fine erythematous punctate eruption that appears within 1 to 4 days after the onset of the illness. The erythema blanched with pressure. The skin can be pruritic, but usually is not painful. Dissemination of the trunk and extremities occur over 24 hours. It is usually more prominent in flexural areas, axial, popliteal fossa, and inguinal folds. It may also appear more intense at dependent sites and sites of pressure, such as the buttocks. Eventually, scarlet maculas are seen overlying the generalized erythema. Boiled lobster appearance, how called. Another distinctive facial findings is a flushed face with circummoral pallor. The cutaneous rash lasts for 4 to 5 days, followed by fine desquamation, one of the most distinctive features of scarlet fever. The desquamation phase begins 7 to 10 days after resolution of the rash, with flakes peeling from the face, peeling from the palms and around the fingers occur about a week later and can last up to a month or longer. The extent and duration of this phase are directly related to the severity of the eruption. Scarlet fever complications. So there are different complications after scarlet fever disease. After cause this disease, cervical lymphadenitis, otitis media, and or mastoiditis, ethmoiditis, peritonsillar abscess, sinusitis, bronchopneumonia, meningitis, septicemia, osteomyelitis, and septic arthritis, and acute renal failure from post-streptococcal glomerulonephritis and myocarditis. Appropriate evaluation and early intervention with antibiotics are essential to prevent these disorders. Rare but lethal yearly toxin-mediated sequelae include myocarditis and toxic shock-like syndrome. A lethal form of streptococcal infection is capable of producing the toxic streptococcal syndrome. Late complications of group A streptococcal infection include rheumatic fever and post-streptococcal glomerulonephritis. Very important known about differential diagnosis. It is very difficult in any cases. The differential diagnosis includes all the causes of fever accompanied by erythematous eruptions. Recurrent cases of scarlet fever have been reported from reinfection with strains unrelated to Streptococcus pyogenes. The cutaneous eruption of fifth disease may be confused with that of scarlet fever, but the affected child is usually well appearance and afebrile. Rubella and measles may appear similar, but the presence of conjunctivitis, purulent rhinitis, and cough are helpful clues to the diagnosis of measles. In addition, the eruption of measles usually begins behind the ears and on the scalp and forehead, not on their torso. Rubella typically begins on the head and face. Other viral exanthematous, such as caused by Epstein-Barr virus, enterovirus, and human immunodeficiency virus infection. Non-infectious disease that should be considered include Kawasaki disease, acute lupus erythematosus, mobile-form drug eruption, and juvenile rheumatoid arthritis. Other problems to be considered include the following: enteroviral infection and non-specific viral infection, different plant allergic reaction maybe, and different viral exanthem. Diagnosis. The diagnosis is mostly based on the clinical presentation. Clinical presentations, it is very important part of all diagnostic. However, leukocytosis with left shift presentation and possibility as in philia. A few weeks after convalescence on a standard blood test and urine tests are part of a complete medical workup. The following studies are indicated in scarlet fever: throat or nasal culture, or rapid streptococcal test, as you see in this picture, Exacta-Pro strepto test, very rapid test, about 5 minutes. Anti-desoxyribonuclease B, anti-streptolizine O, titers antibodies to streptococcal extracellular products can be valuable in confirmation of the diagnosis. In most cases, no any imaging studies are indicated. The complete blood count cells count commonly reveals leukocytosis. The white blood cells count during scarlet fever may increase to 12 to 16 thousand cells per milliliter, with a differential of up to 95% polymorphonuclear leukocytes. During the second week, eosinophilia as high as 20% can develop. Urinalysis and liver function tests may reveal changes associated with complications of scarlet fever. Throat culture remains a criterion standard for confirmation of group A streptococcal upper respiratory infection. Throat culture are approximately 90% sensitive for the presence of group A beta hemolytic streptococci in the pharynx. However, because a 10 to 15% carriage rate exists among healthy individuals, the presence of CAPS is not proof of disease. Direct antigen detection kits have been proposed to allow immediate diagnosis and prompt administration of antibiotics. Several studies of rat kits report results of 95% specificity, but only 70 to 90% sensitivity. Operator technique can also significantly influence the results of this test, of the test. anti-deoxyribonuclease B, and anti-streptozin otitis. Streptococcal antibody tests are used to confirm previous group A streptococcal infection, not during acute phase of this infection. The most commonly available streptococcal antibody test is the ACO test. An increase in ACO titers can sometimes be observed, but is late finding and usually of value only in retrospect time, and streptococcal antibody tests can provide confirmatory evidence of recent infection, but have no value in acute infection and currently are not indicated in this setting. They may be of value in patients with suspected acute renal failure or acute glomerulonephritis. The goals in the treatment of scarlet fever are to prevent acute rheumatic fever. It is complication of scarlet fever. And to reduce the spread of infection person-to-person transmission. The next, to prevent post-streptococcal glomerulonephritis and suppurative sequelae. It is complications too after this disease, such as adenitis, mastoiditis, ethmoiditis, abscesses, and cellulitis, causing by beta hemolytic streptococcal group A, and for goal to shorten the course of illnesses, course of this disease. Antibiotic therapy is the treatment of choice for scarlet fever. Whether antibiotics prevent post-streptococcal glomerulonephritis is still debated in the literature. Penicillin or amoxicillin remains the drug of choice. Documented cases of penicillin-resistant group A streptococcal infections still don't exist. A first-generation cephalosporin may be an effective alternative as long as their patient does not have any documented anaphylactic reactions to penicillin. If this is the case, clindamycin or erythromycin may be considered as an alternative. However, some strains of group A streptococci may not be susceptible to macrolides. A 10 to 14-day course of treatment is usually recommended. It is very important for remain because only in this disease the course of treatment is long, 10 to 14 days. It is very long course of antibiotic therapy. Only this period helpful to prevent complications, rheumatic fever, and glomerulonephritis. Only long course of antibiotic therapy. And clinical improvement should be noted after 24 to 48 hours of antibiotic initiation. The desquamating rash that follows is self-limited with only emollients necessary for care. And at the end of our lecture, I want to present you for you this table where shows different antibiotics with dosage and frequency in adults and in children, and duration 5 to 7 days. It is not correct for scarlet fever, but it is correct for only Streptococcus pharyngitis. In a scarlet fever, you should administer it on a long period, 7 to 10 days. It is very long therapy. Penicillin, amoxicillin, cefalexin, and second-line therapy. It is clarithromycin and azithromycin. On this table, on this slide, we complete our lecture. We speak about two diseases today. It is meningococcal infection and scarlet fever in children. And it is all. The lecture is complete, and goodbye.